Hi everyone, welcome back. This is video 6 of the anemia series. So in the last video, you started to learn about hemolysis. We talked about pathophysiology, labs, we talked about intravascular versus extravascular hemolysis, and you also learned that the cause of hemolysis are either intrinsic or extrinsic to the red blood cells. So now we're going to start learning about the specific diseases, and in this video, I'll cover the intrinsic causes. So let's get started. Okay, so let's start off with a quick 1-minute recap about hemolysis from the prior video so that you all start off on the same page, and then we'll jump into the diseases. So hemolytic anemia is caused by excessive destruction of the red blood cells. So what you're going to be looking for is a normocytic anemia, which means a low hemoglobin and hematocrit with a normal MCV and an elevated reticulocyte level. Now, when the red blood cells get lysed, their internal content is going to spill out, so the labs are going to show elevated serum LDH and indirect bilirubin. So these are the two key lab findings that are going to confirm hemolysis, and the excess bilirubin is going to cause jaundice, and it can lead to formation of pigmented gallstones, as well as the presence of urobilinogen in the urine. Now, hemolysis can be classified based on location, meaning where the red blood cells are getting lysed. So in intravascular, hemolysis is happening in the blood vessels, so hemoglobin is going to get released directly into blood. So we're going to get a decrease in the serum haptoglobin, and then we're going to get hemoglobin in our kidneys, which is going to cause hemoglobinuria and hemosideриnuria. In extravascular, hemolysis is happening in the reticuloendothelial system, so mainly within the spleen and not in the blood vessels. So hemoglobin is going to get degraded in the spleen to bilirubin first, so it does not directly enter the blood. So we do not see these three findings above. Instead, this overactive spleen is going to become enlarged, and the key feature here is going to be splenomegaly. So to summarize these findings real quick, both intravascular and extravascular hemolysis are going to have high indirect bilirubin and high LDH, but the very low haptoglobin and the urinary findings of hemoglobinuria and hemosideриnuria are only seen in intravascular hemolysis. And then finally, hemolysis is also classified based on the underlying cause, meaning what is the defect that is causing the hemolysis. So in intrinsic causes, the defect is within or intrinsic to the red blood cells themselves, whereas in extrinsic causes, the problem is outside or extrinsic to the red blood cells. Okay, so here are the main causes of hemolytic anemia: intrinsic category here, extrinsic category here, and in this video we're talking about intrinsic hemolysis. So the defect that's causing the hemolysis is within the red blood cells themselves. And so in all these intrinsic diseases, the red blood cells have a mutation that's going to make them susceptible to getting lysed, and these mutations can either cause the red blood cell membranes to be defective, as in hereditary spherocytosis and paroxysmal nocturnal hemoglobinuria, or they can cause deficiency of a critical enzyme in the red blood cells, as in G6PD deficiency and pyruvate kinase deficiency, or they can cause a hemoglobinopathy, which is formation of abnormal hemoglobin, as in sickle cell or Hemoglobinuria disease. So in the rest of this video, we're going to go through each of these 6 intrinsic causes, starting with these 2 in the membrane defect category. So let's learn about hereditary spherocytosis, but first we need a quick lesson about these normal red blood cells and how they get their shape. So let's zoom in to the cell membrane of our normal red blood cell right here. And what we're going to see is that the cell membrane out here is actually connected to the cytoskeleton, which is in the cytoplasm here. And this attachment or scaffolding is actually made by a handful of very important proteins called scaffolding proteins. And the 4 main ones that you need to know are spectrin, ankyrin, band 3, and protein 4.2. And the way it works is that spectrin binds the cytoskeleton here, it attaches to ankyrin, ankyrin attaches to band 3, which is in the membrane, and so voila, now we're connected from the cytoskeleton to the cell membrane, and just for good measure, protein 4.2 comes in and reinforces it. You don't need to know the exact steps, you just need to know that these are the 4 key proteins that are important for connecting the cytoskeleton to the cell membrane. And this is all very important because this scaffolding of the cytoskeleton to the cell membrane is precisely the reason that normal red blood cells have a biconcave shape. And this shape is actually really important because it allows them to be deformable or bendy. So as they go through the reticuloendothelial system of the spleen, as they're circulating, they can squeeze through and bend without getting lysed. So the 2 main points here about normal red blood cells are that the cytoskeleton and cell membrane are connected by these scaffolding proteins. And number 2, this connection is really important because it gives the red blood cells their biconcave shape, which makes them flexible in tight spots. Now in hereditary spherocytosis, one of these 4 scaffolding proteins is defective, Ankyrin, which is shown missing here, or spectrum, which is shown missing here, are the two more common causes, but a defect in any of these four can cause hereditary spherocytosis. So we have a deficiency in our scaffolding protein. This means that the cytoskeleton and the cell membrane are not connected in these red blood cells, so we're going to lose the normal red blood cell shape. So instead of biconcave, the red blood cells now have a very round shape, and it looks more like a sphere, and for this reason, they're called spherocytes. And for that reason, of course, the disease is called spherocytosis. So what's the problem with having spherocytes? How are they different than the red blood cells besides just their shape? Well, first, they're just a little bit smaller in size than normal red blood cells, but they still make the same amount of hemoglobin, so that's not really a big deal. The real problem is that these cells are not bendy and deformable, so unlike the normal biconcave red blood cells, spherocytes are not flexible in tight spaces, so as they go through the reticuloendothelial system of the spleen, instead of bending, they actually break and lyse, and this is why hereditary spherocytosis causes hemolysis in the reticuloendothelial system of the spleen, which, as you know by now, is called extravascular hemolysis. Okay, so now let's go through the key features of hereditary spherocytosis. So the problem is a mutation that affects one of these four scaffolding proteins. This is going to cause a defect in the red blood cell membrane and shape, and so we're going to end up with spherocytes. Now it's called hereditary because the mutation is inherited. That means it gets passed on to the offspring, and the most common inheritance pattern is autosomal dominant, and it's actually the only one of these intrinsic hemolysis diseases that has a dominant inheritance pattern. So this is a good thing to keep in mind, help you distinguish it from the other causes. So now let's talk about these clues that are going to help you make the diagnosis. So the first one, most important, is that you're actually going to see spherocytes when you look at a blood smear, and spherocytes have three features that are different than normal red blood cells. So number one, they're more round compared to normal red blood cells. Number two, they don't have a central zone of pallor that you normally see here. And then finally, number three, they're smaller in size compared to normal red blood cells. And this is going to lead into our next clue, which is the red blood cell indices on a CBC. So since spherocytes are smaller in volume than normal red blood cells, then the MCV is actually going to be a little bit low here. Remember that hemolysis, we expect a normal MCV. This is one of the few exceptions in hereditary spherocytosis. The MCV is a little bit low. Now, another clue on the red blood cell indices is going to be a high MCHC. So MCHC stands for the mean corpuscular hemoglobin concentration. And this is basically just describing the average concentration of hemoglobin within each red blood cell. Now, as you just learned, spherocytes are smaller in size than normal red blood cells. So that means that their hemoglobin is going to be more densely packed into a smaller volume. So obviously that means that it's going to be more highly concentrated inside each of these cells compared to normal red blood cells. And this is why the MCHC is high. And for exam purposes, hereditary spherocytosis is one of the very few causes of a high MCHC. So if you see this finding, you should definitely keep an eye out for hereditary spherocytosis. Now, the next important clue is that the hemolysis in hereditary spherocytosis is extravascular only. So the main clinical feature here is going to be splenomegaly, because that's where the hemolysis is taking place in the spleen. And labs are going to show the high indirect bilirubin and LDH that we expect to see in hemolysis. But importantly, you won't see the lab findings of intravascular hemolysis, which would be decreased haptoglobin and hemoglobinuria and hemosideриnuria. You should not see that in this condition. And then the final clue here is the diagnostic test for hereditary spherocytosis, which is called the osmotic fragility test. Basically, the way it works is that you put the red blood cells in a hypotonic solution, which would obviously favor water entering the cells and causing them to swell up. And since these red blood cells have a weaker cell membrane that's not being scaffolded to the cytoskeleton, they're going to be more susceptible to quickly getting lysed. So these cells will be more fragile compared to normal red blood cells in a hypotonic solution. Okay, and now finally, let's talk about treatment. So there's no cure, so the treatment here is going to be mainly supportive, so red blood cell transfusion if needed for severe anemia episodes. But if the hemolysis is severe and persistent, then the ultimate only treatment at this point would be splenectomy, which is surgically removing the spleen. Now, this isn't going to fix the underlying mutation, so the patient's red blood cells are still going to continue to be spherocytes after splenectomy, and that's okay because spherocytes work just fine in delivering oxygen to tissues. There's nothing wrong with them. Their only issue is that they're going to get trapped and lysed in the spleen filter. So now by having removed the spleen, you're eliminating the organ that is lysing them, so now the spherocytes are free to circulate in the body and act like regular red blood cells. So this is very important, very high yield, that in a patient with hereditary spherocytosis who has had a splenectomy, The peripheral blood smear will still show spherocytes, plus an additional finding called Hal-Jolly bodies that I'll explain on the next slide. Okay, so now let's make this point perfectly clear. Let's assume we have a patient with hereditary spherocytosis that's pretty severe, so they need to get a splenectomy. So this is their blood smear before splenectomy. So you can see the spherocyte here. And then this is after splenectomy, and you still see the spherocyte because they still have the mutation that causes spherocytes. So the only difference now is that the spleen is gone. And how do you know the spleen is gone on a blood smear? The answer is Hal-Jolly bodies. And the arrow is pointing to one right here. It's this little basophilic or blue spot inside of the red blood cell, and it's actually composed of a piece of leftover nucleus. So the nucleus is normally supposed to be fully removed from red blood cells as they're maturing in the bone marrow before they get released into blood. But of course, no process is 100% perfect. So sometimes a few of these red blood cells slip through the cracks and end up in the blood. And it's normally the job of the spleen to recognize these red blood cells in the circulation and filter them out of blood. But when someone doesn't have a functioning spleen, such as in this case when it's been surgically removed, then there's nothing to remove these red blood cells. So they're going to stay in the circulation and they're going to be seen on a peripheral blood smear. So the two main takeaways here are, number one, Hal-Jolly bodies on a blood smear indicate absence of a functional spleen. So either it's physically absent or not working anymore. And number two, in hereditary spherocytosis, the blood smear is going to show spherocytes both before and after splenectomy. The only difference is going to be that Hal-Jolly bodies are going to be present afterwards because they're going to confirm that the patient has had a splenectomy. Okay, so now let's learn about paroxysmal nocturnal hemoglobinuria. So first we have to talk about normal red blood cells. So red blood cells are constantly circulating the blood, which means they're constantly being exposed to potential dangers that can lyse them. And one of these dangers is the complement proteins of our immune system. So when the red blood cells are normal, they protect themselves from this complement system by these two proteins right here on the surface called CD59 and CD55. CD59 is known as MAC inhibitory protein. CD55 is known as delay accelerating factor. And the job of both of them is to stick on the surface of these red blood cells, act as security, keep the complement system away. But they need another protein that's going to anchor them to the membrane. And this anchor is a glycolipid protein known as GPI. So normal red blood cells express this GPI protein, which anchors CDs 55 and 59 to the membrane. And in turn, these guys protect the red blood cells from attack by complement. So our red blood cell is healthy, happy, and not getting lysed. Now, in paroxysmal nocturnal hemoglobinuria, or PNH, there's a mutation that prevents this process from working right. The mutation is not in CD55 or CD59, it's actually in that GPI anchor. So the mutation causes absence of GPI, which means that even though the cells have no problem making CD55 and 59, they just can't stick it on their membrane. So now the membrane doesn't have its security guards. So now complement is going to bind to the red blood cell membranes, and it's going to form what's known as MAC, which is the membrane attack complex. And that doesn't sound good. So the membrane is going to get attacked by complement while these red blood cells are circulating in blood vessels. And so the final outcome here is going to be intravascular hemolysis by complement. Okay, so now let's go through all the key features of PNH. So as you just learned, the mutation causes a defect in the GPI anchor, and the gene that's mutated is called the PIGA gene. It's mutated in the hematopoietic stem cells. So this is the gene that encodes for the GPI anchor. So PIGA is the gene that's mutated, and this is an acquired mutation. It's not inherited, and so it's not a germline mutation that gets passed on to offspring. And this is an important feature of this disease because it's the only one of the intrinsic hemolysis diseases that has an acquired mutation. In all the rest of the diseases that we're going to learn today, the mutation is inherited. Okay, so now let's learn about some clues that'll help you make this diagnosis. So the first one is in the name. So paroxysm means episodic attacks, nocturnal refers to nighttime, and hemoglobinuria refers to the findings of intravascular hemolysis in the urine. And it's named this way because classically these patients are going to present with episodes of intravascular hemolysis that happens at nighttime. So they're going to present with pink or red urine in the mornings. And it's thought that this is because at night when we sleep, our breathing slows down. So this leads to acidosis and conditions that are favorable for activation of complement. And so this leads to increased intravascular hemolysis at night. In reality, though, this condition is not limited to nighttime, and any inflammatory stress or infection can actually trigger the immune system and activate complement, leading to hemolysis episodes. The next clue is that the location of hemolysis here is intravascular, so the red blood cells are getting lysed by complement in the blood vessels. This means that in addition to the high indirect bili and LDH, which occur in all hemolysis, we're also going to see a low serum haptoglobin, hemoglobinuria, and hemosideриnuria, and these three all indicate that the hemolysis is intravascular. And if you ever forget this, just think about the disease name. It ends with hemoglobinuria, and that'll remind you that the hemolysis is intravascular. The next clue is the CBC, which is going to often show pancytopenia and aplastic anemia, meaning that in addition to anemia, the white blood cells and platelets are also decreased. And it's thought that this may be due to an autoimmune attack against the stem cells, but the exact mechanism is not known, so you don't need to worry about the details. What you have to know, though, is that PNH is associated with pancytopenia and aplastic anemia. Now, to make the diagnosis, you need a test that confirms the defect on our red blood cells, and that test is flow cytometry. That's the gold standard. So in PNH, flow cytometry is going to show that our red blood cells are CD55 and CD59 negative. This means that they don't have CD55 and CD59 on their cell surface, and that's because they're missing the GPI anchor. And the final thing here to remember is a very important complication of PNH, which is excessive thrombosis or clot formation. The reason for this is that intravascular hemolysis leads to release of large amounts of free hemoglobin and other prothrombotic factors from the red blood cells directly into blood. These are going to promote clot formation and lead to increased risk of forming DVTs. So what you might see in these patients is that they're going to get recurrent DVTs in their extremities, or they're going to get DVTs in uncommon veins like the hepatic vein, and a DVT in the hepatic vein can cause Budd-Chiari syndrome. So these are all indications that the patient has a hypercoagulable state, and that is one of the major complications of PNH. And you may wonder, how can we have excess clots if we said earlier that the platelets are low? And that is true, low platelets would go against clot formation, but the level of the decrease in platelets in this condition is usually not severe enough to prevent clots. So the prothrombotic effects of these factors are going to be much more significant. So the net effect is going to be in favor of a hypercoagulable state. So as a final summary of these clues for PNH, remember this triad of intravascular hemolysis, pancytopenia, and hypercoagulable status. Okay, so we learned the two membrane defect diseases. Now let's move on to the diseases caused by enzyme deficiencies, which are G6PD and pyruvate kinase deficiency. Now let's learn about G6PD deficiency. First, we have to talk about normal red blood cells, and you may want to buckle up because we also have to review a little biochemistry here. So as I said earlier, red blood cells are exposed to lots of elements and they live exciting and dangerous lives. And one of these toxic elements is buildup of reactive oxygen species, such as hydrogen peroxide, inside of these red blood cells. So they need to constantly generate a reliable antioxidant that can handle this oxidative stress and protect them from oxidative damage. So in all cells, including the red blood cells, we have this pathway, which takes glucose 6-phosphate all the way down to ribose 5-phosphate. And this is known as the HMP shunt or the pentose phosphate pathway. And the key rate limiting step of this pathway is the first step, which is mediated by the enzyme glucose 6-phosphate dehydrogenase, or G6PD. In this step, NADP plus is also reduced to NADPH, and this is very important because NADPH is going to come over here and it's going to reduce glutathione, and this reduced glutathione, which is this pink color with the asterisk, is the very important antioxidant inside the red blood cells that's going to deal with reactive oxygen species and protect the red blood cells from oxidative injury. So normal red blood cells are going to express the G6PD enzyme, so the HMP shunt is going to carry on and generate NADPH, which in turn is going to reduce glutathione, which the red blood cells are going to use as an antioxidant, and so our red blood cell is healthy, happy, living its best life, not getting lysed. Now in G6PD deficiency, we have a mutation that causes a deficiency of the G6PD enzyme. Remember, this is the rate-limiting enzyme of the HMP shunt pathway, so the shunt is going to stall at this first step. And the problem is now we don't generate this NADPH, which means we can't use it to reduce glutathione. So the bottom line is a major loss of the cell's superhero antioxidant, which is our reduced glutathione. So as a consequence, the red blood cells lose their protection against reactive oxygen species like hydrogen peroxide, so they become susceptible to hemolysis due to oxidative injury, and this is going to cause both intravascular and extravascular hemolysis. Okay, so now let's go through all the key features of G6PD deficiency. The mutation here causes a deficiency of the enzyme G6PD, which leaves the red blood cells susceptible to hemolysis by oxidative damage via all the steps that we just discussed. The inheritance of this mutation is X-linked recessive, and interestingly, G6PD deficiency is the most common inherited enzyme deficiency in the world. And then finally, the G6PD mutation is found in higher rates in people of certain ancestry, such as from Africa, Asia, Mediterranean, and the Middle East. And this is thought to be an evolutionary advantage because the mutation can offer protection against infection of the red blood cells by malaria. This is a similar phenomenon that we're going to see in sickle cell and thalassemia as well. Okay, now let's talk about the clues that are going to help you with this diagnosis. First is the blood smear, and there are two findings here. Number one is called Heinz bodies. So these are denatured hemoglobin that precipitates inside of the red blood cells. And the reason for this is because oxidative stress damages the hemoglobin. And you can't visualize this on a standard blood smear, so you need to add a supravital stain to see the Heinz bodies. Number two is bite cells, and this is something that you can see on a standard blood smear. And this is exactly what it sounds like. The red blood cells looks like they've had a bite taken out of them, and that's because they basically have. As these red blood cells circulated through the spleen, the splenic macrophages try to selectively remove these Heinz bodies from them. So they basically take a bite out of them, and this leads to the formation of the bite cells. And so this makes a very easy mnemonic for me personally because I love ketchup. So Heinz ketchup makes the red blood cells tastier so that the macrophages take a bite out of them. So the next important clue is the symptoms of G6PD deficiency. Now, most people with this deficiency, the enzyme isn't completely absent, it's just operating at much lower levels. So at normal baseline, they're not experiencing constant severe hemolysis. The hemolysis tends to occur in episodes, and that's going to cause all the usual symptoms and labs of hemolysis that we've talked about, including hemoglobinuria, and that's because there's intravascular hemolysis also going on in G6PD deficiency. So these episodes are going to be triggered by oxidative stress, so things that generate reactive oxygen species, and that's because the main problem here is inability to handle oxidative stress. So the three main exposures that are going to generate oxidative stress are certain foods. Number one, especially fava beans is a board exam favorite for triggering a crisis in G6PD deficiency. Number two, medications, especially specific antibiotics like sulfa drugs, dapsone, and anti-malaria drugs are commonly asked about on exams. And then finally, infections, and that's because a consequence of infection is activation of the immune system, which is going to lead to release of reactive oxygen species, which can harm these defenseless red blood cells. And finally, to make the diagnosis of G6PD deficiency, the confirmatory test is a G6PD enzyme analysis, and it will be low. Basically, you're checking the level of this enzyme's function. And the super high yield thing here is that you have to wait for the acute hemolysis event to be over before you do this test. If you do it during an acute episode, you might get a falsely high result, and that's because the cells that lack the enzyme are lysed and dead, so you're only getting results from those red blood cells that have higher expression, and this might conflate the enzyme activity, and so it should be avoided. So the two important things to remember here are, number one, the diagnostic test is to check the levels of the G6PD enzyme activity, and number two, this test should be done after recovery, not during an episode of acute hemolytic anemia. And then finally, I don't have much on treatment here, and that's because really the main treatment is to avoid these triggers of oxidative stress that we talked about. Okay, so now let's talk about pyruvate kinase deficiency. So here we have an autosomal recessive mutation cause a defect in the enzyme pyruvate kinase. And this is a very important enzyme because it catalyzes the final step of glycolysis by converting PEP to pyruvate. So when this enzyme is defective, that means no more glycolysis, it's going to get stalled, and this is especially problematic for our red blood cells because remember, red blood cells don't have mitochondria, so glycolysis is their only hope for energy, and once glycolysis is shot, they have no alternative way to make ATP. So now our enzyme is defective, we can't make ATP in our red blood cells, and without the energy from ATP, the ion pumps that are in the cell membrane will no longer function. So this is going to cause the ion and fluid balance in the cells to become significantly abnormal, and as a consequence, the red blood cells are going to become dehydrated, which is going to make them very rigid. And as you would expect, rigid red blood cells do not survive the tight spaces of the reticuloendothelial system. So as they circulate through the spleen, they're going to get hemolyzed. So the final outcome of pyruvate kinase deficiency is going to be extravascular hemolysis in the spleen. Now let's talk about the key clues to help you recognize this diagnosis. First clue is the onset of symptoms. Because this is a very significant enzyme deficiency, it's usually going to present in the newborn period, and as a consequence of the significant hemolysis, the serum bilirubin levels are going to be really high, which of course is going to cause jaundice. So the classic presentation of pyruvate kinase deficiency is a newborn with significant jaundice. The next clue is the blood smear. It's going to show Burr cells, otherwise known as echinocytes. So these are red blood cells that have little small bumps on their surface. And to me, echinocytes look like Lisa Simpson's hair from The Simpsons. The final clue has a biochemistry tie-in, which you need to know for step 1. Because glycolysis is stopped at the final step, the upstream substrates are going to build up, and 1,3-BPG right here is going to get converted to 2,3-BPG. So what you need to know is that pyruvate kinase leads to increased levels of 2,3-BPG. That's the main point. Now, the main effect of high levels of 2,3-BPG is decreased affinity of hemoglobin for oxygen. So if we look here on the oxygen hemoglobin dissociation curve, what we see is that compared to normal, we have a rightward shift in the curve with high levels of 2,3-BPG. And what this means is that the hemoglobin has less affinity for oxygen. So it's basically more willing to let go of the oxygen, and it promotes oxygen unloading and increases the efficiency of oxygen delivery to our tissues, which is a good thing to do when we have anemia. So this is an important physiological adaptation to pyruvate kinase deficiency. Okay, so we finished learning the enzyme deficiency diseases as well. Now the only category left is diseases caused by hemoglobinopathy, which are sickle cell and Hemoglobinuria disease. So now let's learn about sickle cell disease, but first we have to talk about normal red blood cells. So the main content of normal red blood cells is hemoglobin, and in adults, the normal hemoglobin has 2 alpha globin chains and 2 beta globin chains, and this normal adult hemoglobin is called hemoglobin A. Now, in sickle cell disease, there's a point mutation in the beta globin gene. This means there's a single nucleotide that's changed, and this is going to cause a missense mutation, which means that we have an amino acid substitution. So instead of what's normally supposed to be glutamic acid, we end up with valine. And so this hemoglobin with this mutation is called hemoglobin S. Now, what could go wrong if you have only one single incorrect amino acid in this big, huge protein? What's the big deal? Well, as it turns out, a lot. The problem with this mutation is that it's what's called non-conservative. What that means is that these 2 amino acids have opposite characteristics. Glutamic acid was hydrophilic, but valine is hydrophobic. So when it comes time for the protein to fold into a 3D structure, this is going to cause major problems. And specifically, this hemoglobin S is going to want to aggregate when it's not bound to oxygen. So when the red blood cells are exposed to a low oxygen environment, hemoglobin S is going to polymerize inside them, which causes a change in the red blood cell shape from the normal biconcave to a crescent shape, which looks like a sickle. And so that's where the name sickle cell comes from. And there are 2 problems with sickled red blood cells. Number 1, they're susceptible to hemolysis. And number 2, they clump in small blood vessels and cause occlusion. Okay, so now let's go through the key features of sickle cell disease. We have a mutation in the beta globin gene, which is on chromosome 11. This causes an amino acid substitution from glutamic acid to valine, which forms hemoglobin S, which polymerizes when it's not bound to oxygen, and this leads to sickling of the red blood cells. This is an autosomal recessive mutation. That means both copies of the genes must be abnormal for the disease to happen. And if there's one normal and one abnormal copy, in other words, someone is heterozygous, this is known as sickle cell trait or a carrier. And these people usually have no symptoms unless they're exposed to extreme hypoxic conditions, such as in high altitude. And then finally, this mutation is found in higher rates in people of certain ancestry, such as from sub-Saharan Africa, Mediterranean, and Middle East. And this is thought to be an evolutionary advantage because of protection against infection of the red blood cells by malaria. And this is similar phenomena we see in G6PD and thalassemia as well. Now let's talk about the key findings to help clue you into this diagnosis. First is the peripheral blood smear. The key to this diagnosis is to actually visualize the sickled red blood cells on a smear, and you can identify them pretty easily because their shape looks like a sickle or a crescent moon, and I'll show you a blood smear with this finding soon. The confirmatory test, though, is hemoglobin electrophoresis, and that's because you want to actually show that instead of the normal hemoglobin A, you have the abnormal hemoglobin S, and that's exactly what you see on hemoglobin electrophoresis here. Very high amounts of hemoglobin S, very little hemoglobin A, and an increase in the amount of fetal hemoglobin. And this is an important, helpful adaptation by the body. That's because fetal hemoglobin is made up of 2 alpha and 2 gamma chains. So it uses gamma instead of the beta globin, which is mutated here. So our body, being smart and all, compensates for this condition by making more of the hemoglobin that doesn't use the abnormal beta globin chain. And then the final clue to watch out for actually ties in with this fetal hemoglobin. So sickle cell anemia does not cause any symptoms or any problems in the fetus or in the newborn. And by the way, this is also what we see in beta thalassemia. That's because the fetus and the newborn rely mainly on fetal hemoglobin, which, as you just learned, does not use beta globin. So it's completely unaffected by this mutation of the beta globin gene. Now, once the baby reaches around 6 months of age, this is when we usually switch to mostly hemoglobin A. And at this age is usually when the disease presents symptoms. So the punchline is that in sickle cell disease, the symptoms are not present in the fetus and newborn period. So let's look at some pictures to make sure you understand the clues we just talked about. So over here is a standard peripheral blood smear of a patient with sickle cell disease. And what you see inside the black circles are these sickled cells. And you can clearly see that they have a very different crescent shape compared to the normal red blood cells. Now over here, we have a hemoglobin electrophoresis. It's actually not a real electrophoresis. It's my drawing of what one would look like. We have 3 columns. So over here, we have the normal adult hemoglobin. And what you see there is a heavy band indicating lots of hemoglobin A. All the way over here on this side, we have sickle cell disease. So this is someone who has 2 abnormal copies of the gene. So you see no hemoglobin A, some fetal hemoglobin, and lots of hemoglobin S. And then in between them, we have sickle trait. This is someone who's heterozygous, so 1 normal and 1 abnormal gene copy. And what you see here is most of their hemoglobin is a normal hemoglobin A with only a little bit of hemoglobin S. And that's why this is mostly asymptomatic unless in significant hypoxic conditions. Okay, so now the main thing that's left to do is to talk about the complications of sickle cell disease. In other words, what problems are caused by these sickled red blood cells, and there are 2 main sets of complications. First one is hemolysis. So sickled red blood cells get hemolyzed, and this is just like all the other intrinsic hemolysis diseases, leads to similar findings. And if this was the only problem with sickle cell disease, it wouldn't be as severe. However, sickle cell disease has a second very significant complication, and that is vaso-occlusion. So these sickled red blood cells occlude small blood vessels and cause obstruction of blood flow. And this is very important and unique. Sickle cell disease is the only hemolytic disease that causes vaso-occlusion. And in fact, most of the severe symptoms of it are due to this vaso-occlusion, not the hemolysis. So what I'll do now is go through the key things you need to know about each of these complications, starting with the hemolysis first. So let's talk about the features of hemolytic anemia and sickle cell disease. Sickle red blood cells are susceptible to hemolysis, and the hemolysis is both intravascular and extravascular. And the key findings are related to 3 things. Number 1 is anemia, which of course is going to be normocytic with elevated reticulocytes, as you would expect with hemolysis. Number 2 are the hemolysis labs, which are going to be elevated serum LDH and bilirubin. High bilirubin causes jaundice and can form pigmented gallstones. And if there's significant intravascular hemolysis, it can also cause hemoglobinuria. And then finally, number 3, there's excessive erythropoiesis. In other words, the body is compensating for the severe hemolysis by trying to generate new red blood cells at a very high rate. This primarily happens in the bone marrow of the axial skeleton, so places like the cranium, ribs, vertebrae, and pelvis. And a classic board exam clue of severe hemolysis in sickle cell disease is a thickened skull on an X-ray, which is called the crew cut sign. There's also red blood cell production outside the bone marrow. This is called extramedullary erythropoiesis, and this mainly occurs in the liver and the spleen. So both of these organs are going to become enlarged, causing hepatosplenomegaly. One caveat with splenomegaly, though, later in the disease, the spleen is going to infarct and will actually shrink in size, but in the early stages, it can be enlarged along with the liver due to their active role in erythropoiesis. So now let's switch to learning about the features of vaso-occlusion in sickle cell disease. Sickle red blood cells are inflexible and sticky, so they can clump in small blood vessels and cause occlusion of blood flow. This will cause tissue ischemia, which leads to the clinical symptoms of vaso-occlusion in sickle cell disease. So there are a number of these symptoms that you need to know, and I'll go through the main ones here and explain them one at a time. First one is acute pain crisis. This is also known as vaso-occlusive crisis. It's the most common acute symptom of sickle cell disease. This is basically an acute episode of severe diffuse pain, usually involves bones of the extremities as well as the back, can also cause chest and abdominal pain, and it's caused by diffuse sickling of red blood cells, leading to vaso-occlusion, ischemia, and severe acute pain. Next is dactylitis. This is painful swelling of the hands and feet, and it's caused by vaso-occlusion affecting these areas. So a typical exam question would show you a picture of swollen fingers like this. And the key to remember here is that it's usually the earliest clinical manifestation of the disease. So it's most commonly seen in children and often as their first presenting sign of having sickle cell disease. Next complication is autosplenectomy. This means the body loses the spleen itself. This is caused by vaso-occlusion to the spleen, which leads to spleen infarct, and eventually the spleen shrinks and becomes non-functional, and this is also known as functional asplenia. The problem is that the spleen has a very important role in filtering bacteria out of blood, especially those bacteria that are encapsulated. So the consequence of this autosplenectomy is we don't have a functioning spleen. So these patients are at much greater risk for developing sepsis from encapsulated bacteria. And the main one to watch out for is strep pneumonia, but others include Neisseria meningitidis, Haemophilus influenza, and Salmonella. Next complication is osteomyelitis. This means infection of the bone. Vaso-occlusion in the bone makes it more susceptible to becoming infected by bacteria, and the loss of the spleen, which we just talked about, makes this an even greater risk, especially by one of the encapsulated bacteria named Salmonella. So what you need to know is that patients with sickle cell disease are at greater risk of osteomyelitis by Salmonella bacteria. This is a very high yield association. And just an interesting sidebar, Salmonella is often found in large colonies on reptiles, and this is why children with sickle cell disease are told not to have reptiles as pets to reduce the risk of Salmonella infection and osteomyelitis. Next complication is acute chest syndrome. This is caused by vaso-occlusion of the pulmonary blood vessels. So this is going to lead to local damage and irritation of the lungs. So the key findings here are going to be cough, chest pain, low oxygen sats, and infiltrates on the chest x-ray. And it's very important to recognize this condition. This is another can't miss complication of sickle cell disease because it's associated with high mortality as well. And it is, in fact, the most common cause of acute death in patients with sickle cell disease. So those were the top 5 complications up there. There are a few more down here that I'll talk about quickly. So vaso-occlusion in the brain can lead to stroke. Vaso-occlusion in the heart can cause myocardial infarction. Vaso-occlusion in the kidneys can cause necrosis of the renal papilla and lead to painless hematuria, and this occurs in both people who have sickle cell disease and those who are heterozygous and have sickle cell trait. Now, I said earlier that sickle cell trait is a benign condition and doesn't have many symptoms, and that's generally true, but this is the main exception. So what you need to know is that renal papillary necrosis and hematuria occur not only in patients with sickle cell disease, but also those with sickle cell trait. Now, vaso-occlusion in the erectile tissue can lead to impaired blood flow and cause a low flow priapism, which is a painful abnormal erection. And then finally, vaso-occlusion to the bone can cause avascular necrosis. The name literally means death of tissue, necrosis caused by lack of blood flow, avascular. So in this condition, bones undergo necrosis due to ischemia. This leads to chronic severe joint damage, and it's going to cause chronic pain and limited joint movement. So let's wrap up the complications of sickle cell disease by talking about a couple of topics that can be confusing. Make sure that they're clear for you. Number one is what happens to the spleen in sickle cell disease. So at first, as an infant and a toddler in very, very early childhood, the spleen grows and gets large. This is because the spleen is performing extravascular hemolysis. It's getting congested by sequestering red blood cells, and it's performing extramedullary erythropoiesis. So all these things are going to lead to splenomegaly. But later during childhood, the spleen is going to shrink. This is because of vaso-occlusion, which causes repeated splenic infarcts. So as a consequence, the spleen is going to become small, fibrotic, and non-functional. And this is known as autosplenectomy or functional asplenia. So during childhood and for the rest of life, this is going to be the status of the spleen. The major clinical consequence of this is increased risk of sepsis from encapsulated bacteria, as we just talked about. But also don't forget about Hal-Jolly bodies. So even though sickle cell patients still physically have a spleen, once it's no longer functional, it can't clear out the red blood cells with Hal-Jolly bodies. So what you need to know is that in sickle cell disease, you should expect to see Hal-Jolly bodies on the blood smear, and this confirms that autosplenectomy has occurred. So that was number one, the spleen. Topic number two is about the term crisis. You're going to hear different types of crisis mentioned in relation to sickle cell disease, and it refers to an acute severe exacerbation in the disease. So I'll explain them here so you know what each of these mean and how they're different from each other. So the splenic sequestration crisis occurs when we have a large active spleen. So this is primarily only an issue during early childhood. The problem is that this big active spleen is going to sequester or pull out large volumes of red blood cells out of the circulation. So this leads to a severe acute and possibly even life-threatening exacerbation of the anemia because red blood cells are being stored in the spleen rather than circulating in blood. Aplastic crisis is caused by parvovirus B19. It infects the red blood cell precursor cells in the bone marrow and shuts down production. And this also causes a severe acute exacerbation of the anemia. But the clue here is that the retic count will be unexpectedly low. And that's because this acute issue is caused by halting of the red blood cell production in the bone marrow. So when sickle cell disease has an aplastic crisis, that means there's an infection by parvo B19. There'll be a sudden drop in hemoglobin and hematocrit, and the retic count will be low. And then the final crisis is the vaso-occlusive crisis. It's also known as acute pain crisis or sickle cell crisis. And we talked about this one already. The problem is acute episodes of vaso-occlusion causing diffuse pain, and it's the most common acute symptom associated with sickle cell disease. Okay, so let's finish up sickle cell disease by talking about its treatment, and let's start with preventative care. So one very high yield medication is hydroxyurea. It's very commonly used in sickle cell disease because it increases the body's production of fetal hemoglobin. Remember, this is the type of hemoglobin that uses gamma instead of beta globin, so it's unaffected by the mutation in sickle cell. And by increasing the levels of fetal hemoglobin, we're essentially reducing the ratio of the abnormal hemoglobin S. So overall, it's going to be very helpful for reducing the symptoms of sickle cell. And it's not exactly known how hydroxyurea does this, so you don't have to worry about that part. But what you do need to know is that hydroxyurea is used for sickle cell disease because it increases fetal hemoglobin. Next, supplements of iron and folate are also very important. Remember, these patients have a very high reticulocyte count, which means they're constantly building new red blood cells in overdrive mode. So they're burning through their stores of iron and folate and are at high risk of developing a secondary anemia from either iron or folate deficiency. So they need to stay ahead by supplementing. And then the next important prevention is related to infection. Remember, the problem is asplenia, so high risk of infection. And the two key steps here are number one, immunizations, and number two, prophylactic antibiotics, which are given in childhood because the immune system hasn't matured yet. Now let's move on to treatment of acute episodes. So for the acute severe anemia, the treatment is to quickly replace those red blood cells by transfusion. For the vaso-occlusive crisis or the pain crisis, the goal is to, number one, treat the acute severe pain. So giving adequate analgesia, very, very important. And then number two, reverse the sickling process of the red blood cells by giving IV fluids and oxygen. Remember that sickling is favored in hypoxia and dehydration. So treating with fluids and oxygen is going to reverse it and help relieve the symptoms. And then finally, you always have to keep in mind the other complications of sickle cell disease like acute chest and sepsis. Some of these have very high mortality if they're not caught quickly, so high index of suspicion in any acute presentation is always prudent here. Now, of course, all of these treatments are just supportive, not curative. The only cure would be gene editing. CRISPR has been used in a rare few cases. It works by reactivating a dormant gene for fetal hemoglobin, and so it increases fetal hemoglobin levels much more efficiently than giving hydroxyurea, and it's been very effective in treating people with severe sickle cell disease, and more of this treatment at the gene level is on the horizon for near future. Okay, so now let's talk about Hemoglobinuria disease. The underlying defect here is very similar to sickle cell. So just like in sickle cell disease, the mutation is in the beta globin gene, chromosome 11, and it also involves replacing glutamic acid, but in this case, it's being replaced by lysine. This is going to make the hemoglobin less soluble. This is called hemoglobin C, and it forms crystals inside of the red blood cells because it's less soluble. So the key word here is crystals, so you can remember hemoglobin C for crystals. And this is going to lead to extravascular hemolysis only, so no intravascular hemolysis here in hemoglobin C disease. Just like sickle cell, the inheritance for this one is also autosomal recessive, and just like sickle cell, there's a higher prevalence in certain geographic areas such as West Africa, and again, this is thought to be due to being protective against malaria. Now let's talk about the clues to make this diagnosis. So on a blood smear, the two key findings are, number one, hemoglobin crystals inside of red blood cells that are shaped like rods, and number two, the presence of target cells. So these two are the key findings on a smear that are consistent with hemoglobin C disease. The way to confirm the diagnosis is, again, just like sickle cell, we would do hemoglobin electrophoresis. In this case, we have a very low hemoglobin A and some increase in fetal hemoglobin, and of course, very high levels of hemoglobin C. Now, unlike sickle cell, the hemolysis here is very mild, so anemia is less severe. And then unlike sickle cell disease, there's no vaso-occlusion problem in hemoglobin C disease. So overall, the symptoms are much less severe. And the final thing you should know, especially for exams, is that some people have the hemoglobin hemoglobin genotype of SC. That means that one copy encodes for hemoglobin S of sickle cell disease, and the other copy encodes for hemoglobin C. And what you need to know here is that the clinical symptoms in these patients is milder compared to those that are hemoglobin SS, meaning those who have sickle cell disease. Okay, so we covered a lot of high-yield diseases. Let's end with a summary table of everything that we just talked about. So hereditary spherocytosis is mostly autosomal dominant. The defect is in the cytoskeleton scaffolding proteins. Some important findings here were spherocytes, increased MCHC, and extravascular hemolysis by the spleen. Paroxysmal nocturnal hemoglobinuria is the only one that is an acquired mutation. The defect was in the GPI anchor. It led to lysis by the complement system and intravascular hemolysis. G6PD is X-linked recessive. The defect is in G6PD, which leads to decrease in NADPH and decreased reduced glutathione. The oxidative triggers are the key here that lead to hemolysis, such as fava beans, some antibiotics, and infections. And the key smear findings here are bite cells and Heinz bodies. Next was pyruvate kinase. This was autosomal recessive. The defect was in the pyruvate kinase enzyme of glycolysis, and the key finding here was newborn jaundice. Next was sickle cell disease. This is autosomal recessive. The defect was in the beta globin chain that led to aggregate and lead to sickling of the red blood cells and caused not only hemolysis, but also vaso-occlusion. And then finally, Hemoglobinuria disease, also autosomal recessive, also a defect in the beta globin chains that caused formation of crystals, in this case only very mild hemolysis and no vaso-occlusion. Final point here is that these top two diseases in the yellow color are problems where there's a membrane defect in the red blood cells. These two in the blue are problems where it's an enzyme deficiency in the red blood cells. And finally, these two are a problem with abnormal hemoglobin formation in the red blood cells. Okay, that's it and that's all. Please drop a comment below and let me know what you thought of the video. And if you thought it was good, please hit the like button, share it with others. And then finally, don't forget to subscribe so you don't miss out on upcoming content. But for now, thank you for watching and I'll see you next time.